Good afternoon, everybody. Thank you, first, the KGA, for inviting me to give this case discussion. I have a challenging thing to do now. I know most people are hungry now for lunch, and I'll try to be quick, but this will not be like a classic talk. It will be more a discussion with the panelists here and with you guys, with some voting, with some questions. Although I will give a background about the topic, because some of the audience are not like an IBD specialist or gastroenterologist, so just some background what is pouchitis. So we'll discuss a case about chronic pouchitis. These are my disclosure. So this is just a nice figure from the American College of Gastroenterology, just to summarize what I mean. So patient in IBD, use patient with ulcerative colitis who does have a colectomy, usually for like failed medical therapy. Usually some of them have a pouch, which is usually part of the terminal ileum, or like the ileum. Like you see the U-shaped here. It's not working, the pointer. Sorry, and this is what we call it, a pouch. And then the rest of the ileum, we call it pre-pouch. So maybe I'll point it here. So this is the pouch. We call it a pouch. This is like the connection between rectum and the pouch. There is a small area maybe remaining of the rectum called cuff, the cuff-cuffisis. And this is for remaining ileum, or the proximal ileum, we call it pre-pouch ileum. This can get inflamed, and we call it pre-pouch ileitis, just to understand the setting. And you can disease of the pouch can be inflammatory diseases, can be structural diseases of the pouch. So the J pouch, or we call it ileal pouch anal anastomosis, can have an inflammation, which we call it pouchitis. And pouchitis is the most common inflammation that happens of the pouch post surgery. And usually, like, it's the idiopathic pouchitis. Chronic antibiotic refractory pouchitis is becoming a more common nowadays, with some patients have refractory disease, and usually they need maybe biological or advanced therapy. Crohn's-like disease of the pouch. So if the pouch starts to have Crohn's phenotype, such as deep ulcers or fistulas or pre-pouch ileums inflamed, then you think about Crohn's-like disease of the pouch, and usually those are 10% of the patients. And the treatment of each disease is different. So the inflammatory pouch disease, which mainly this chronic pouchitis will be one of them, is first we have the idiopathic pouchitis, which is most common diffuse inflammation of the pouch. Usually patients have abdominal cramps, rectal bleeding, urgency, and those symptoms usually, unfortunately, does not correlate well with the endoscopic finding. And there is many theories behind the pouchitis. We know because there is altered bowel after surgery, there is microbiome alteration, and there is many theories behind it, and risk factor and genetic risk factors. Usually first-line treatment is an antibiotic. The commonest one is metronidazole and ciprofloxacin, and some patients require long-term therapy. And there is other type, which is chronic antibiotic-dependent pouchitis, are those patients who usually needed antibiotic for long-term, and those patients difficult to be off antibiotic, but we try to cope these patients like in the least antibiotic possible and tailored antibiotic just to prevent resistance. And the third component are the patients who have chronic antibiotic refractory pouchitis, despite giving antibiotic therapy. Those patients can still have symptoms and disease, and those patients may require advanced therapy. So Crohn's disease, like of the pouch that I mentioned earlier, usually affect 10% or less than 10% of those patients, and they start to having like phenotype of Crohn's disease, such as fistula, fibrostenotic disease, or pre-pouch ileum disease. And those patients may need advanced therapy. Primary sclerosing cholangitis associated with pouch is also putting like by the American College of Gastroenterology as a separate entity, because those patients usually have like a difficult to treat phenotype. Usually like pouch with a PSC is usually difficult to treat and to manage, and they usually require advanced therapy, and we don't know exactly why, but also this is like another theories about the microbiome alteration with PSC. And there is other less common types of pouch, like ischemic pouchitis due to hyperperfusion post-surgery, and usually this is managed surgically, and there is some data about hyperbaric oxygen, and infection of the pouch, such as the colon and the ileum can get infection, so C. diff and CMV and other infection you need to look at. And there is an infection with the cuff that I mentioned you earlier, the cuffitis, the remaining maybe colon between the rectum and the pouch can get inflamed. It's called Pouchitis, and each subtype has different treatment modalities. So let's just give you an introduction, let's move on to the case. So this is a 35-year-old female diagnosed with ulcerative colitis at the age of 20 in 2010. She was medically refractory. She was started in infliximab, did well initially, then had secondary loss of response to infliximab, mechanistic failure, then she was switched to ustekinumab. In 2019, she was admitted with acute severe ulcerative colitis, was not refractory to steroid, and back then the decision was that she had to have colectomy. And she had a colectomy, and then she had a pouch, IPAA. Before having biologic, earlier she passed medical history, she had a cycle like 5-ASA and azathioprine before getting her biologics. Social history, she's a school teacher, non-smoker, single. So initial pouch function, like the couple of years after the surgery, was good. Her normal bowel habit was 4 to 6 per day. First episode of pouchitis was in 2022. She presented with abdominal pain and cramp or bloody diarrhea. Her CRP back then was 17, hemoglobin 10.5, rest of her lab normal. Stool tests for C. diff and other pathogen were normal. She had a pelvic MRI just to rule out any Crohn's of the pouch was not normal. Pouchoscopy showed inflamed pouch with mucosal ulceration, friability, and erythema. And this is the PDI score. I'll talk about that later. And the biopsy showed acute and chronic inflammation with crypt abscesses. So this is a question to you and maybe to the panel. So which scoring system you use in clinical practice? Do you use the modified PDI score, subjective endoscopic evaluation, the PASS score, the Chicago classification of the pouch, or other scoring system?
Maybe I'll start. I'll go first. I don't know if we routinely use it, but the PDAI I think would be the most commonly used instrument. I think we tend in practice just to collect the components of that spontaneously, stool frequency, urgency, fever, and endoscopy and histology. So I think de facto we do the PDAI, although I can't say we routinely actually report a number in our
Any
notes.
other thoughts here about the scoring system? Okay. Any voting back then? Okay, so the majority use the modified PDI score. So the PDI scores include endoscopy, clinical and endoscopic features, and the modified one with adding histology. The PASS score is has the modified PDI score has acute histology, whereas the PASS score has a chronic histology. The Chicago classification kind of New York score, it has morphology as well, like phenotype. So if the patient has fistulas and other, it's also included in the Chicago classification of the pouch score. So we have many scores, but I think the majority we use MDPI score, but we don't have a one score that's all we use. And our scoring system, unfortunately, do not correlate well with the endoscopic activity of the disease. So the second question is, what is your first-line treatment for idiopathic pouchitis? Which antibiotic would you use? Can we vote? Voting, so back there, any voting? Okay, so this is an easy one. So the majority will choose ciprofloxacin and metronidazole. And why is that? Because the majority, can you stop the vote? Okay, so because majority of evidence we have for ciprofloxacin, so if you can see the ECG recommend ciprofloxacin metronidazole for 2 weeks. The echo, the majority of the patient, metronidazole do well, or ciprofloxacin. Side effect, it says less with ciprofloxacin. They also echo recommend you can use antidiarrheal medications such as loperamide. If you go with the AGA recommendation, the same thing, ciprofloxacin or metronidazole for 2 to 4 weeks. the combination approach may be more effective than single approach, and alternative therapy will be an oral vancomycin. So kind of all bodies agreed on this thing to do. So she responded well to a 2 weeks course of ciprofloxacin metronidazole. However, from 2020 to 2023, she had recurrent episodes of idiopathic pouchitis, 3 to 4 episodes requiring antibiotic therapy over 3 to 4 years. In 2024, she has worsening diarrhea over 8 months, 8 to 12 bowel motions per day with blood in the stool, also nocturnal symptoms, urgency. She lost 4 kilograms. So she went abroad to Leuven for further opinion and treatment. So investigation showed inflamed pouch mucosa with ulceration, fibrotic erythema. Biopsy showed acute and chronic inflammation with crypt abscesses. Stool for pathogens were negative. CRP was 30. Hemoglobin 10.F 1133. Fecal calpro 176. Christopher lab normal. Imaging were all normal. So she got another 4 weeks course of antibiotics, ciprofloxacin and metronidazole, with partial response. She also got VCL3, nominal improvement. She had budesonide rectal form, was ineffective. So what is your next treatment option here? Pouch revision, fecal microbiota transplantation, advanced therapy, another course of antibiotics, others. Anyone want to comment, Doctor?
So after failure of antibiotics,
anyone want to comment here?
After failure of antibiotics, so the second step will be a longer period of antibiotics, which was done, and then local tropical budesonide, which was also done. So now the next step would be definitely biologics. And
Dr. Mohammed, will Dr.
I agree. So if you're antibiotic refractory now, multiple sessions despite taking good duration of antibiotics, then you went with the enema, budesonide enema, and you're still having pouchitis, then the next step will be starting advanced therapy like biologics.
So the
choice of biologic is what we can discuss.
Yes. So I think the panel agreed on biologics. But I think there is some of the audience was a pouch revision, but I don't think pouch revision is would be the next option by now. I think we're trying to induce advanced therapy. So moving on, I think maybe we don't need the voting because it's just. But don't stop the voting, please. I'll do it without voting. Okay? So if you consider advanced therapy, which therapy now you will choose? Anti-TNF, vedolizumab, JAK, selective IL-23s, SLMP inhibitors. So what will be your choice here?
the recommendations, all of them could be possible. However, vedolizumab is the only one with the RCT, controlled RCT. So I'll just start with option B.
So you all agree on vedolizumab? Okay.
Well, the evidence is there, so Vedo might be the best first choice if she did not fail it before.
She didn't fail Vedo, yeah. She only is ticagrelor and infliximab. So I agree with the panel. I'll talk to you why. So some review of the literature. This is like a systematic review meta-analysis we did a few years ago. We published in the Journal of the Canadian Association of Gastroenterology, which Dr. Marshall was the editor-in-chief back then. So this is mainly, you can see all the studies that included pouchitis and CP, the chronic pouchitis. PI is the CD Crohn's disease of the pouch. PI is pre-pouch ileitis and chronic pouchitis CP. So majority of these studies are observational data. There was some RCTs for adalimumab, but there's no big study. The majority of this was based on observational data. But then recently, we come the EGNIS trial, which we all know, this is a randomized controlled trial that may be the largest, even though we have 102 patients, but that will be a large number for pouchitis, for randomized patient of vedolizumab versus placebo, all got antibiotic, and we can see and they use the MDPI, modified pouch disease index score, and in terms of remission and response, there was better in patients who received vedolizumab versus placebo, and this is the best evidence we have so far. If we go on like also the GI recommendations, this is a bit like ECG. This was around 2017, so this is before the INT'L trial where they recommended biologic, especially vedolizumab. And if you go the echo, this is also was maybe before this is I think also was 2017 or 18, was before the INT'L trial. So they said antibiotic effective, you can go with the infliximab is effective, or adalimumab or alternative biologic. But this is the AGA, this is 2024 guidelines. If you can read, the panel suggests antibiotic evaluation, then patient can take anti-TNF therapy or any other biologic, but then they say here vedolizumab is the only advanced therapy to date that has received regulatory approval for the European Medical Agency, and I think because this is the best evidence we have, a randomized controlled trial, so maybe vedolizumab would be our first line option. You want to say something, Mohammed?
I'll ask you later.
So she was started on vedolizumab, 300 milligram at week 0 to 6, then every 8 weeks. Week 12, symptomatically improved. Week 35, she was in clinical remission, CRP5, hemoglobin 11.5, albumin 37, fecal cal 106, Pouchitis PDI score of 3, which is in remission. Now, the question is, that may be difficult, how do you gonna follow her up now? Would you do CRP, fecal cal, Pouchitis, clinical, and all of them, but what is our threshold? Well, the problem is like, are you gonna do CRP, maybe it's a fecal cal, will you follow her with fecal cal, are you gonna do pouch? What is your normal fecal cal in a pouch patient? That's a difficult thing to, I don't know, we don't have a good answer, but what is what to use in practice? We're gonna get like, do a Pouchitis every now and then, or how are you gonna follow this patient?
It's a great question. And no, I don't think we really know what the threshold fecal calprotectin would be in this scenario. I mean, it's a relatively small surface area, but it's distal. You'd think that it would be a sensitive biomarker, but I'm not sure we really know that. I have to say most of the follow-up would be symptomatic. You know, I think in this condition, contrary to a lot of other variants of inflammatory bowel disease, we're very focused on mucosal healing. I don't think we're there yet with pouchitis. So I think if the patient is feeling well on therapy, you know, we do pouchoscopy intermittently. We do measure CRP, but I'm not sure that I would change therapy based on residual inflammation and pouchoscopy in someone with symptomatic remission.
Yeah, I agree with you. Like, we don't have a good like threshold for fecal cal, but also we know like endoscopy and like symptoms do not correlate well with endoscopy. So would you, Mohammed, scope her every year or so, or what would you do?
Well, in pouchitis, most patients, once they develop symptoms, they're really symptomatic. I mean, it's not like Crohn's ileitis when they sometimes come without symptoms. So most of them, they'll come rushing to your clinic saying, I have increased diarrhea, pain, heaviness, and so on. So the symptoms here might correlate with inflammation. Now, as Prof said, I agree that I won't change treatment based on minimal inflammation because sometimes you have to be very logical. You cannot control pouchitis 100%. But if the patient is doing well, let's just hope she stays well.
Okay. So now she's doing well, she's fine, but the difficult question, she comes back to you in clinic, she wants to get married now and she's asking if she can get pregnant. So the first question, yes or no? And if no, what type of pregnancy would you recommend? Would you recommend normal delivery, C-section? Can she get pregnant or not? And this is a difficult question too. Anyone has, what is your opinion?
Pregnancy shouldn't be an issue. It's the way of getting pregnant is the issue.
Yes.
So some of them, they lose the fecundity or ability to conceive.
Yeah, fertility will be low for sure, yes.
Yeah.
The chance of it.
So I usually discuss that with a female in that age pre-going for IPA because I had some horrible cases in clinic. No one discussed that with them. And then when you tell them, afterward, they will just break into tears. So you have to discuss that with them before going for IPA. And at the same time, she can get pregnant, but she might need to go for IVF.
Although it's worth saying that laparoscopic pouch construction is associated with far better fertility outcomes than open surgery, but still I completely agree that you're obliged to mention that before I think she goes through that procedure of pouch construction.
Yeah. Do you think like C-section would be like, I think, safer option for normal delivery, just not to play around the pouch? Or
Professor Dehor from Leuven once presented in one of the meetings transanal approach to form a pouch and so on. And according to the evidence, he showed that there is no effect on fertility because he will not open the pelvis. So that's one way of looking at things. Now, whether you go for normal delivery, I'll prefer C-section. Depends on the sphincter tone.
Yeah, I think this is one of those scenarios where we would tilt towards C-section because of sphincter integrity.
Yes.
You know, pouch function is precarious at the best of times, and any compromise of sphincter function can really have disastrous effects on quality of life. So it's not an absolute thing. I think we can look for patient preference here.
Yeah.
But I would not. I would probably suggest a C-section mainly for continence issues.
Okay. So I think we. Yes, would I say something, Fahad?
No, nothing.
Yeah, so I think we agree that she can get pregnant, but her chances of getting pregnant is low. And if she gets pregnant, maybe C-section is a better option than normal delivery. Regarding the monitoring, yes, yeah. And we said like patient follow-up on patient maybe symptoms, and maybe you can do biomarkers. We don't have a solid evidence on the way of surveying those patients. Any questions, anything you want to add for the discussion before we finish for lunch? So I think pouchitis is like one of the difficult things, as Dr. Prof. Marshall mentioned, difficult to deal with, especially patients with chronic pouchitis refractory to antibiotics, and then when they develop complication, they have ugly complication and difficult to treat. I think it's good now that we have some evidence for those refractory cases for biologic and advanced therapy, and I think there will be more data of more advanced therapy for these populations.
So, Mohammed, just a question for the whole floor, actually. That patient received already anti-TNF and she failed that. Now, the two questions, actually. If she did not get anti-TNF before, she just chose to go for IPA without even trying biologics, will you go combo or mono? That's one. And if she failed Vedo and she previously had infliximab, what options we have?
So the first question, you're talking about mono combo versus use like immunosuppressive therapy. We use mono infliximab versus infliximab with thiopurine, for example. Yeah, you know, that my practice is really evolving. I have to say, despite what was on some of the previous slides, I'm not using combination therapy as systematically as I once did because we have so many other options, and because I think we can get around some of the sensitization challenges by actually looking at trough levels. So I probably monotherapy to your first question.
Okay.
And if they fail
Vedo.
TNF and Vedo,
Yeah.
well, I think Fahad made a good point. I think anything is on the table for treatment of pouchitis.
The recommendation is still like you can still use a biologic that it be used pre-colectomy.
Yep.
It still doesn't preclude it. So if I would use anti-TNF again, so me and myself, I would do a dual just organization, especially in infliximab.
One question here.
Yes.
So for pouchitis, Shehab, how long you use Cipro and Flagyl, and do you use it small dose or the usual dose, and for how long?
For which one?
Chronic pouchitis.
Usually 2 to 4 weeks.
Okay.
I use the regular dose. I'm not sure about you. Yes.
Regular dose or smaller?
2 to 4 weeks.
I'd use regular dose, unless you're in the kind of the long-term antibiotic prophylactic kind of strategy, which I cut it down by half. But if I'm treating pouchitis, I agree. Standard dose, 2 to 4 weeks.
Okay. Mohammed. I think, do you want to say something, Mohammed? Okay, I think we're done here for this session. Thank you, and see you after lunch.